Welcome back to the Deep Dive. Today we're tackling a real monster of a topic.
Oh, it's a monster.
And I don't use that word lightly. I mean, we're looking at something it's the bread and butter physiology, right?
Absolutely. But it's also, a minefield, a complete minefield in the operating room.
Exactly. We are talking about anemias and red blood cell disorders.
It's a massive topic. And frankly, if you are sitting for your MD anesthesiology exams, especially, say, the Gujarat University papers, this isn't just a clinical topic. It's a survival topic.
It's a survival topic. I like that.
It shows up everywhere. 20-mark, long answers, short notes, and it is an absolute favorite for Viva traps.
It is. I was looking through the source material we've pulled together for this. We've got Robbins' pathology, Miller's, Harrison's, the ARC guidelines, David Chambers' physiology, Yao, and Artuzio. It's a serious stack.
It is.
And what struck me is that anemia seems so simple on the surface. Low blood.
Yeah.
But when you dig in, it's a labyrinth.
It is. And that's the mistake a lot of residents make. They treat it superficially.
Like hemoglobin is low, I'll transfuse.
Exactly. But for the exam, and more importantly for safe practice, you have to understand the why. You need the kinetics, the compensation, the crisis management.
So that's our mission today. We're going to take this mountain of textbooks and sort of distill it into a high-yield audio guide.
And we'll structure it. We'll structure it just like you'd want to write a 20-mark answer.
Perfect. From the molecule right up to that decision in the OR.
Which is the best way to learn it. I always say, structure is king in the exam. If you ramble, you lose marks.
Okay, so let's start where the examiners want us to start. Framing the problem. We can't just say low hemoglobin, can we?
No, that won't get you any marks. You need a precise physiological definition.
Okay.
So according to Robbins and Miller, anemia is defined as a reduction in the oxygen transporting capacity of the blood.
So it's a functional definition, not just a number.
Exactly. And it usually stems from a decrease in the red cell mass to subnormal levels.
But you do need the numbers for the WHO criteria, right? Examiners love a specific cutoff.
Oh, absolutely. You have to quote the WHO. For the exam, you say, anemia is hemoglobin less than 130 grams per liter for men.
Okay, 130 for men.
And less than 120 grams per liter for non-pregnant women.
And for pregnant women, it's lower.
It drops to 110. Yeah.
Okay, so 130, 120, 110. Clear. But why does this matter so much to us? Why is it, as Miller calls it, a disease modifier?
Because Miller's point is crucial. Anemia is an independent risk factor for bad perioperative outcomes. It's not just a bystander.
So it actively makes things worse.
It exacerbates cardiac risk. It exacerbates renal risk. It basically just lowers your entire margin of safety.
So when they ask about this in a long question, they're not just testing pathology.
No. They are testing your ability to think like a physician and an intensivist. You're managing the oxygen economy of the entire body.
Right, the oxygen economy. Let's get into the physiology then. This is where we really need to dig in.
Right, high-yield physiology. You have to start with the cell itself, the red blood cell.
It's a flexible biconcave disc.
A flexible biconcave disc, about 6 to 8 microns in diameter.
And that size is very specific, isn't it? It's not random.
Not at all. It's critical because those cells have to squeeze through capillaries that are sometimes only 3 microns wide.
So they have to literally fold in on themselves.
They have to fold. And if they lose that deformability, like in, say, spherocytosis or sickle cell disease, they get trapped.
And destroyed in the spleen.
Exactly. But their main job, as David Chambers points out, is transport. Oxygen from the lungs to the tissues and CO2 back. Simple as that.
And inside that disc, doing all the work, is hemoglobin.
Correct. Hemoglobin is a tetramer. In adults, that's HbA, so 2 alpha and 2 beta chains.
Each with a heme group.
And each heme group holds an iron atom. And that iron atom is like a little claw that grabs the oxygen molecule.
Okay, this brings us to the equation. I feel like every anesthesiology exam comes back to the oxygen delivery equation at some point.
The DO2 equation. You absolutely have to know this. If you are listening to this, you should be visualizing writing this down.
It's the holy grail of anesthetic physiology.
It is. So oxygen delivery, or DO2 equals cardiac output, times the oxygen content of arterial blood.
Okay, let's break that down because the variables here are everything.
Right. So DO2 equals CO times, and then in brackets, 1.34 times HB times SO2, plus
the dissolved part.
The dissolved part, which is 0.003 times PaO2.
Okay, let's unpack those constants. 1.34, that's Huckner's constant. It's the amount of oxygen each gram of hemoglobin can carry.
When it's fully saturated, yes. HB is your hemoglobin concentration, and SO2 is your saturation.
And that second part, the dissolved oxygen, that's usually negligible, right?
Under normal conditions, at atmospheric pressure, yes,
Yeah.
it's tiny. The hemoglobin is doing, 98% of the heavy lifting.
So here is the Viva question I can see coming.
I know the one.
If your hemoglobin drops by half, does your oxygen delivery drop by half?
And mathematically, if you just stare at the equation, you'd say, yes, it's a linear variable.
But physiologically, that's not what happens.
No, it doesn't, because the body compensates. When hemoglobin drops, cardiac output almost always increases.
Why? Is it just a sympathetic response? Just speeding up the pump?
That's part of it, sure. But there's a huge rheological factor, viscosity.
The thickness of the blood.
Yes, David Chambers explains this really well. Red cells make blood thick. If you have fewer red cells, the blood becomes thinner, less viscous.
So it flows more easily.
It flows more easily, stroke volume goes up, cardiac output goes up, and that helps maintain your DO2 even as the HB is falling.
That is such a critical point. It's not a linear drop. So the goal isn't just a number on a lab report.
Yeah.
It's actual tissue oxygenation.
That's what the ARC guidelines are all about. We treat oxygenation, not just the hemoglobin number.
Okay, so that sets the stage. Let's move into the absolute core of any exam answer on this. Classification.
Yes. You said earlier, examiners hate random lists. They despise them.
So if you get asked about anemia and just start rattling off types,
You will lose marks. You have to classify. You have to show you have a structure for your thinking.
so what's the best strategy? There are a couple of ways to do it.
There are two main ways, and for a top-tier answer, you should probably mention both.
Okay.
The first is morphological. It's based on the size of the cell.
Your MCV, mean corpuscular volume.
Exactly. This is what we use in practice every day. You look at the CBC,
So you have microcytic.
MCV less than 80 femtoliters. Classic examples are iron deficiency and thalassemia.
Normocytic.
MCV between 80 and 100. This is your acute blood loss, hemolysis, renal failure, that sort of thing.
And finally, macrocytic.
MCV greater than 100. Here you're thinking B12 or folate deficiency, maybe liver disease or hypothyroidism.
Okay, micro, normo, macro. Simple.
Yeah.
What's the second way to classify?
The second is etiological. This looks at the kinetics, the cause of the shortage.
So why is the red cell count low?
Exactly. And Robbins breaks this down beautifully into three main buckets.
Bucket 1.
Decreased production, the factory is broken. This could be a bone marrow problem like aplastic anemia or a nutritional deficiency.
Bucket 2.
Increased destruction. This is all your hemolytic anemias. The cells are being made, but they're being destroyed too quickly.
And bucket 3 is just loss.
Blood loss. Straightforward hemorrhage, either acute or chronic.
So in an exam, would you lead with one over the other?
I would probably lead with the etiological classification to show I understand the mechanism, the pathophysiology. Then I'd say, and clinically we investigate this using a morphological approach based on the MCV.
That shows you can think like a pathologist and a clinician.
That's the goal.
All right, let's dive into the common types, the ones that are guaranteed to show up as short notes or in a Viva. We have to start with iron deficiency anemia.
IDA, the most common anemia in the world by far.
And the pathophysiology is pretty direct, right?
It is. It's a depletion of your iron stores. No iron means you can't synthesize no hemoglobin.
And the cause is almost always.
Chronic blood loss. You have to think that first. In men and postmenopausal women, you assume it's a GI bleed until proven otherwise.
And in younger women.
Usually menstrual loss. But you also have to consider nutritional deficiency, especially in certain populations we see in public hospitals.
Okay, let's talk labs. This is a classic compare and contrast question. What are the lab findings that just scream iron deficiency?
Harrison's is the go-to for this. First, low serum iron, obviously, but the absolute key is ferritin.
Ferritin is your storage protein.
It's the iron in the bank. In IDA, the bank is empty. So ferritin is low, usually less than 15 micrograms per liter.
And what about the transport proteins?
So the TIBC, total iron binding capacity, goes high.
Why is that?
Think of transferrin, the main transport protein, as a fleet of empty taxicabs looking for iron passengers. If there's no iron, you have loads of empty cabs just circling around.
So the capacity to bind is high.
The capacity is high, but the transferrin saturation is very low because there's nothing to carry.
Got it. And clinically, what do we see, besides just being pale?
On the peripheral smear, you'll see microcytic, hypochromic cells, little pale cells. You might see pencil cells.
And the classic textbook signs.
You get those specific signs like spoon-shaped nails, which is koilonychia, a sore tongue, glossitis, and pica, that strange urge to eat non-food items like dirt or clay.
Fascinating. Okay, let's swing to the other end of the size spectrum. Macrocytic anemia, specifically megaloblastic.
This is a completely different physiological problem. It's a fantastic thing to explain in Aviva.
What's the core issue here?
It's a deficiency in either vitamin B12 or folate, and you need both of those for DNA synthesis.
Okay, so if DNA synthesis is impaired, what happens to the developing red cell?
While the cytoplasm keeps growing just fine, RNA synthesis is unaffected, but the nucleus, it can't mature properly because it can't replicate its DNA.
So you get this big bloated cell with a young, immature nucleus.
Exactly. The classic term you must use is nuclear cytoplasmic asynchrony.
Nuclear cytoplasmic asynchrony. That sounds like a guaranteed mark.
It is.
Now here's a huge trap I know exists. Differentiating B12 from folate deficiency.
A massive Viva trap. The key is neurology. B12 deficiency, which is often called pernicious anemia if it's due to a lack of intrinsic factor, causes neurological damage.
What kind of damage?
It causes demyelination of the dorsal columns and the lateral corticospinal tracts in the spinal cord.
So patients will present with what?
Numbness, tingling, paresthesias, ataxia. And if it's severe, you get subacute combined degeneration of the cord. It's irreversible if not caught early.
And folate deficiency.
Does not cause neurological damage. That is the single most important distinction.
And that's why you can't just blindly treat a macrocytic anemia with folate.
Never. Because if it's actually a B12 deficiency, the folate might partially correct the anemia, masking the problem.
But the neurological damage will just keep getting worse.
It will progress unchecked. It's a huge clinical pitfall.
And what do we look for on the blood smear here?
The other hallmark besides the big red cells is hypersegmented neutrophils.
Meaning?
Neutrophils with 5 or more nuclear lobes. It's a dead giveaway for megaloblastic anemia.
Okay, let's tackle the one that always seems to confuse people. Anemia of chronic disease.
Yes, or anemia of inflammation, as it's sometimes called now.
Why is it so tricky?
It's tricky because it can look like iron deficiency. The cells can be microcytic or normocytic, but the underlying mechanism is completely different.
It's driven by inflammation.
Precisely. Chronic inflammation triggers the release of cytokines, particularly interleukin-6 or IL-6.
And IL-6 does what?
It stimulates the liver to produce a key peptide called hepcidin.
Hepcidin, that's the key word you need to mention.
That's the one. Hepcidin is the master iron regulator. In this state, it blocks the release of iron from macrophages and from gut absorption.
So the body basically locks its own iron away.
It does. It's an evolutionary response, probably to hide iron from invading bacteria. But the result is you have plenty of iron in storage.
But the bone marrow can't access it to make red cells.
Exactly. Functional iron deficiency.
So the labs are going to look different from ID.
Critically different. Your ferritin, the storage iron, will be normal or even high. The safe is full.
But the serum iron will be low because it's locked up.
Correct. And the TIBC, unlike an IDA, is usually low. The body isn't making more empty taxicabs because it's trying to limit iron circulation.
So that's the key differentiator.
Yeah.
High ferritin means chronic disease. Low ferritin means true iron deficiency.
That's the algorithm.
Fantastic. Let's move on to the really dramatic stuff, the hemolytic anemias.
Ah, an exam favorite. The physiology is so active and interesting.
So hemolysis is just accelerated destruction.
Right. The RBC lifespan drops way below the normal 120 days.
And the main way we classify this is intrinsic versus extrinsic, right?
Correct. Intrinsic means the problem is with the red cell itself. It's defective.
So things like membrane defects.
Like hereditary spherocytosis, or enzyme defects like G6PD deficiency. Or, the big one, hemoglobin defects like sickle cell disease.
And extrinsic.
Extrinsic means a perfectly normal red cell is being destroyed by some outside force.
Like what?
Antibodies in autoimmune hemolytic anemia. Or mechanical trauma getting sheared apart by a prosthetic heart valve or caught in fibrin strands in DIC.
What's the classic clinical picture of a patient with hemolysis?
You look for the triad: anemia, jaundice, and splenomegaly.
Okay, break that down.
Well, the anemia is from the destruction. When all those red cells break, they release their contents, including bilirubin.
Which caused the jaundice, unconjugated bilirubin specifically.
Yes, and the spleen is working overtime, trying to clear up all the cellular debris, so it gets enlarged. Splenomegaly.
And the labs will reflect this overdrive.
Absolutely. The bone marrow goes into overdrive to compensate, so you see a really high reticulocyte count.
The factory's working 247.
Exactly. LDH, an enzyme inside red cells, goes way up because it's released from all the broken cells, and haptoglobin goes down.
Okay, explain the haptoglobin part.
Haptoglobin is a scavenger protein. Its job is to bind to any free hemoglobin floating around in the plasma to get it cleared.
So in massive hemolysis, there's a ton of free hemoglobin.
So all the haptoglobin gets used up trying to clean it. A low haptoglobin is a very sensitive marker for intravascular hemolysis.
That's a great explanation. Okay, let's deep dive into a couple of the inherited disorders because these are absolutely critical for us as anesthetists. Let's start with sickle cell disease.
A huge, huge topic. The pathophysiology is a single-point mutation in the beta-globin gene.
Valine for glutamic acid.
Correct. And this creates hemoglobin S, or HbS. Now, when HbS is deoxygenated, it polymerizes.
It crystallizes.
It forms these long, rigid rods inside the red cell that distort it into that classic sickle or crescent shape.
And these sickle cells are a disaster for circulation.
A complete disaster. They're rigid, they're sticky, they can't deform to get through capillaries, so they logjam the microvasculature.
Causing ischemia.
Ischemia, which causes excruciating pain and, over time, cumulative organ damage. We call this a vaso-occlusive crisis.
So for the anesthetist in the operating room, this is a minefield of triggers. What are we desperately trying to avoid?
You have to avoid anything that promotes sickling. The classic triggers are what I call the terrible T's, though the textbooks list them as hypoxia, acidosis, hypothermia, and dehydration.
Hypothermia is a huge one for us.
It's a massive one. Cold causes vasoconstriction, which slows blood flow, which gives the cells more time to deoxygenate and sickle. You must keep these patients actively warmed.
Acidosis shifts the curve right, promoting oxygen release and deoxygenation of HbS.
Exactly. Hypoxia is the most obvious trigger. And dehydration makes the blood more viscous, which also promotes sludging and occlusion.
There's a specific post-op complication that Yao and Artuzio highlight. It looks like pneumonia, but it isn't.
Acute chest syndrome. This is a leading cause of death in these patients.
How does it?
It usually happens a couple of days after surgery. The patient develops a new infiltrate on the chest x-ray, they get a fever, they become hypoxic.
Sounds exactly like pneumonia.
It does, but it's actually vaso-occlusion happening in the pulmonary vasculature. You have to have a high index of suspicion and treat it aggressively.
With what?
Oxygen, aggressive pain control, antibiotics to cover any potential infectious trigger, and often exchange transfusion to reduce the percentage of HbS.
Got it. Okay, what about the other major hemoglobinopathy, thalassemia?
Thalassemia is a different beast. It's a quantitative defect. You simply aren't making enough of one of the globin chains, either alpha or beta.
That's a production problem.
It's a production problem that leads to ineffective erythropoiesis. The marrow works like crazy but produces defective cells that get destroyed.
For the anesthetist, besides the chronic anemia itself, what's the big long-term issue?
Iron overload.
Hemosiderosis.
From years and years of blood transfusion.
Exactly. These patients can receive hundreds of units of blood over their lifetime. All that iron has to go somewhere.
And it deposits in organs.
It deposits in the liver, the endocrine glands, and most critically for us, in the heart.
Causing cardiomyopathy.
A restrictive cardiomyopathy, arrhythmias, heart failure. You absolutely have to have a thorough cardiac workup before putting these patients to sleep. Okay, just briefly, let's touch on a couple of other important disorders. G6PD deficiency.
That's an enzyme defect. G6PD is an enzyme that protects the red cell from oxidative stress.
So if you're deficient.
And you're exposed to an oxidative stressor, so certain drugs like sulfonamides, some antimalarials, even methylene blue, you can trigger massive acute hemolysis.
Good to know. And hereditary spherocytosis.
That's a membrane protein defect, usually spectrin or ankyrin. The cell loses its biconcave shape and becomes a sphere.
And spheres don't squeeze through the spleen very well.
They don't. They get trapped and destroyed. The main anesthetic point is that many of these patients have had a splenectomy, which can make them hypercoagulable or susceptible to certain encapsulated bacteria.
And finally, polycythemia, the opposite problem.
Right. Too many red cells. The issue here is hyperviscosity. The blood becomes like sludge.
Which increases the risk of
Thrombosis?
Yeah.
Stroke, MI, DVT. Anesthetically, you might need to perform a preoperative phlebotomy to get their hematocrit down below 55% before an elective procedure.
Okay, that's a great tour of the pathologies. Let's get practical. A patient comes to your pre-op clinic. You suspect anemia. How do you investigate this logically without just ordering every test in the book?
You need an algorithm. And Harrison's has a great one. Start with the simple stuff. A CBC and a reticulocyte count.
And the reticulocyte count is the first major fork in the road.
It is the absolute key. because it tells you if the bone marrow is responding appropriately.
So you calculate the reticulocyte index.
And if it's low, say less than 2.5, it tells you the factory is shut down. It's a production problem.
So you're thinking iron deficiency, B12, folate, marrow failure.
Exactly. But if the retic index is high, greater than 2.5, it tells you the factory is working overtime to keep up with losses.
Which means the problem is either hemolysis or bleeding.
Precisely. That one test splits your differential diagnosis in half. It's incredibly powerful.
And after that, you'd look at the peripheral smear.
Essential. A well-read smear is invaluable. You look at the shapes. Spherocytes point to hemolysis. Schistocytes, these fragmented red cells, are a huge red flag for DIC or mechanical valve trauma.
Sickle cells are obvious.
Obvious. And target cells can suggest thalassemia or liver disease.
Okay. Now, here's a question that's always fascinated me from a physiological standpoint. You see these patients in clinic, they walk in, they're talking to you, but their hemoglobin is like 5. How are they not dead?
Physiological compensation. The body has a remarkable ability to adapt to chronic anemia.
And there are 4 main mechanisms you need to be able to list for the exam.
4 key mechanisms. Let's go through them. Number 1.
Increased cardiac output.
We talked about this. Lower viscosity and sympathetic drive increase the flow. The heart literally pumps more blood faster.
Okay, number 2.
Redistribution of that blood flow. The body is smart. It clamps down on blood vessels to less critical areas like the skin and the gut.
And shunts that blood to the brain and the heart.
To the vital organs. That's why chronically anemic patients are so pale. It's active vasoconstriction.
Number 3.
Increased oxygen extraction. The tissues at the other end just become more efficient at pulling oxygen off the hemoglobin that does arrive.
So the extraction ratio goes up.
It goes way up. Normally, we only extract about 25% of the oxygen delivered. In severe chronic anemia, that can climb to 50% or 60%.
And finally, the biochemical one, number 4.
The shift of the oxyhemoglobin dissociation curve.
The ODC.
In chronic anemia, the red cells start producing more of a substance called 2,5,3-diphosphoglycerate, or 2,5,3-DPG.
And 2,5,3-DPG does what exactly?
It wedges itself into the hemoglobin molecule and stabilizes the deoxygenated, or T state.
Which makes the hemoglobin less sticky for oxygen.
Precisely. It shifts the curve to the right. And a rightward shift means that for any given partial pressure of oxygen, the hemoglobin gives up its oxygen more readily to the tissues. It facilitates unloading.
Brilliant. So understanding the compensation is key to understanding the next part, the anesthetic implications. So we have an anemic patient. Surgery is necessary. What's the plan?
Preoperatively, the first question is this elective or an emergency?
If it's elective.
You optimize. You do not proceed with an elective case in a patient with an untreated hemoglobin of 7. You find the cause and you fix it. You give iron, you replete the B12, you give erythropoietin if it's renal failure, you buy time and fix the problem.
But if it's an emergency, you don't have that luxury.
Then you have to manage the physiology you're given. Your intraoperative goal is simple. Maintain oxygen delivery, that DO2 or 2,2.
Okay, so how do we do that?
Well, look at the equation. DO2 or 2 depends on cardiac output and oxygen content. So you must avoid things that depress the myocardium. You need to keep the tank full. Maintain their preload aggressively.
And on the other side of the coin, you minimize oxygen demand.
Yes. You aggressively treat anything that burns oxygen unnecessarily.
Huh.
You prevent shivering with forced air warmers. You ensure excellent analgesia to control pain. You manage anxiety.
Okay, let's talk about the big one, the transfusion trigger. This is the classic Viva trap. Doctor, at what hemoglobin do you transfuse?
And if you just blurt out a number like 10 or a hematocrit of 30, you will fail the station.
The old 10-30 rule is dead.
It's ancient history. You must give a nuanced, guideline-based answer.
So what is that safe answer?
The safe answer is, I treat the patient's physiological state, not the number on the lab report.
And then you give the guidelines.
Then you quote the guidelines from Miller or the ASA. You say, generally, if the hemoglobin is less than 6, transfusion is almost always indicated.
Okay, less than 6 you transfuse.
If it's greater than 10, it's rarely indicated.
And the gray zone?
The gray zone is between 6 and 10. And in that range, the decision is based on clinical evidence of inadequate oxygenation.
So you're looking for signs of organ ischemia.
Exactly. Is the patient tachycardic despite adequate fluid resuscitation? Are they hypotensive? Are there new ST segment changes on the ECG? Is their lactate level rising? If you see those things, you transfuse, regardless of whether the number is 7.2 or 8.5.
That is the expert answer they're looking for.
Yeah.
What about the choice of anesthetic? General versus regional?
It's a great debate. Many people prefer regional because you avoid airway manipulation and the respiratory depressant effects of general anesthetics and opioids.
Seems logical.
It is, but there's a major caveat. A dense sympathetic block from a spinal or an epidural causes significant vasodilation.
And if your anemic patient is relying on that compensatory vasoconstriction to maintain their blood pressure.
A spinal can cause a catastrophic drop in blood pressure and perfusion. So if you do choose regional, you have to be incredibly gentle with your dosing and extremely vigilant with your hemodynamics.
Okay, let's talk worst case scenarios. Complications during the surgery.
The ultimate enemy is tissue hypoxia. If our oxygen delivery fails to meet demand, organs start to fail. You get acute kidney injury, myocardial infarction, postoperative cognitive dysfunction.
And is there a specific disaster we should mention in an exam?
The one to mention to show you're thinking about the whole picture is DIC disseminated intravascular coagulation,
Which can be triggered by a major hemolytic transfusion reaction or massive hemorrhage.
Exactly. It's a consumptive coagulopathy. The clotting cascade gets activated systemically, forming thousands of microthrombi throughout the circulation.
Which consumes all your platelets and clotting factors.
It uses them all up. And so, paradoxically, the patient then starts to bleed uncontrollably from everywhere, from their 5E sites, from their surgical wound, from their airway.
The paradox of thrombosis and hemorrhage at the same time.
That's the one. And the labs will show it. Low fibrinogen, prolonged PT and PTT, sky-high D-dimers, and those fragmented red cells, the schistocytes, on the smear.
And treatment is chaotic.
Treatment is about treating the underlying cause, stop the transfusion, treat the sepsis, and replacing the factors that are being consumed. You have to give FFP, cryoprecipitate, and platelets. We call it feeding the fire.
Feeding the fire. That's a terrifying but very memorable image.
It is.
Before we summarize, let's do a quick-fire exam trap segment. What are the specific mistakes you see students make over and over?
Okay. Trap number 1. We mentioned it, but confusing B12 and folate. Remember, only B12 has the neurological symptoms.
Got it. Number 2.
The sickle cell acute chest syndrome trap, don't just call it pneumonia post-op. You have to recognize it as a vaso-occlusive crisis. It's a different pathophysiology.
Right. Number 3.
Failing to classify, just listing anemias randomly shows you don't have a mental framework. Always start with a classification, either morphological or etiological.
And a 4th one.
Knowing the difference between sickle cell trait and sickle cell disease, trait, HBS, is generally benign unless under extreme physiological stress. Disease, HBS, is a constant high-risk state.
Good point. And if this is a written paper, should we be using diagrams?
Oh, absolutely. A good diagram is worth 100 words. If you're talking physiology, draw the oxyhemoglobin dissociation curve and show the rightward shift with an arrow.
What else?
Draw out the Harrison's algorithm for investigating anemia, starting with that reticulocyte index. Or draw a simple table comparing the iron studies in IDA, chronic disease, and thalassemia. It shows the examiner you can synthesize information clearly.
And write out the DO2 equation.
Always. Write out the full oxygen delivery equation right at the start of your physiology section. It's a power move.
Okay, let's bring this all home. We've covered a massive amount of ground. Can you give us a final high-yield summary for someone about to walk into their exam?
I can. Let's do it as bullet points.
Perfect.
1. Anemia is reduced oxygen carrying capacity, a functional definition. 2. Always classify your anemias either by size, MCV, or by cause, kinetics. The body compensates via increased cardiac output and a rightward shift of the ODC, driven by 2,3-DPG. 4. In sickle cell disease, avoid the triggers: hypoxia, acidosis, hypothermia, dehydration.
5.
Transfuse based on physiological need, not just a number. Use the 6 to 10 gray zone and look for signs of ischemia. 6. Always ask why the patient is anemic before you start your anesthetic.
And a final one.
Manage the entire oxygen economy. Keep your supply, your DO202 as high as possible, and keep your consumption as low as possible.
Perfect. Anemia is a symptom, not a diagnosis.
That's the final thought. Always find the underlying diagnosis.
This has been an incredibly thorough deep dive. Thank you so much.
My pleasure. It's a foundational topic. You get this right, and a lot of other critical care physiology just falls into place.
And to you, the listener, take a second right now. Grab a piece of paper. Can you draw that ODC from memory? Can you write out the full DO2 equation? If not, maybe hit rewind on the last 30 minutes.
Good advice.
Good luck with the Gujarat University exams or whatever challenge you're preparing for. We'll see you on the next deep dive.